Good afternoon, everyone. My name is Guillermo Beades. I'm a partner here at Frier Levitt. I'm joined by my associate, Phoebe Nelson, and one of our trusted experts, Jim Tudor of Empower Healthcare. I want to welcome everyone and thank you for joining us today on wound care audits and navigating payer scrutiny, coding challenges, and audit response strategies. Now, a little bit about us and why you should even listen to us today. Like I mentioned before, my name is Guillermo Beades. I'm a partner here at Frier Levitt. I co-chair the firm's insurance defense group, and in my practice, I, along with my associate Phoebe, represent healthcare professionals in overpayment demands, audits, recoupments, and every other kind of payer issue you can imagine. We've been thankful enough to work with trusted experts like Jim Tudor of Empower Healthcare, where as a team, we've successfully overturned many Medicare revocations, some in the multiple millions of dollars. We also do work reinstating billing privileges, defending against license suspensions across multiple jurisdictions, and also work on other payer and licensing challenges that our clients have. We've also represented providers in various compliance issues and white-collar matters involving the False Claims Act, anti-kickback statute, and some more state-specific violations like Cody law here in New Jersey. I'm joined today by my colleague, Phoebe Nelson. Phoebe is an associate of ours. She's been with the firm for a couple of years now, and she's done a significant amount of work in payer audits. And wound care audit space has really skyrocketed in auditing and scrutiny. And it's something that we saw on the horizon, a couple of years ago when we were writing about this. It started first in the realms of podiatry, and now we're seeing it move into other areas. And Phoebe is one of the associates who has worked extensively on these types of cases. And she has some insights that she's going to share with you today about some of the new areas of attacks, including the designation of these products as being experimental, which is truly not the case. Jim Tudor, our co-presenter here, he'll have a lot to say about the coding and the documentation attacks. And I'll turn it over to Jim to introduce himself.
Yeah, thanks, Guillermo. I have been gainfully employed in this whole billing business, or all things concentric to billing, coding, compliance, for the better part of 40 years. And I've been a certified professional coder since 1997. I can't believe where all the time has gone. I guess I'm just having a lot of fun with this stuff, right? Audit defense has been my specialty in this industry for probably about the last 8 to 10 years. And, if I do say so myself, we've got a pretty strong record with successful appeals, as Guillermo mentions, overturning revocations. The number of dollars that we've saved clients through our combined efforts is really astonishing. I don't know if we can get a tangible number on it, but it's multi-millions. And that's because, when we get an audit, we go through everything with a fine-tooth comb and debunk everything to the greatest extent of our abilities. And a lot of practices just kind of say, okay, well, can I just write them a check and be done with this? But I would never recommend anybody do that, because the audits are faulty enough so as to give you plenty of room to challenge them. Lots of experience here with ALJs, administrative law judge, depositions, and things of that like. And just today is, this is really, very timely. Phoebe isn't the only wound care expert in the room with us today. I've been, deeply immersed in these audits, to the extent that I kind of feel like I know it from, like the back of my hand. And I really do appreciate the opportunity to discuss all of this today. And I think I'm going to have some very salient pearls of wisdom for everyone attending.
Thanks, Jim. And before we get started, I just want to remind everyone for a few housekeeping items. The webinar is being recorded, and you'll receive a link to the access and the on-demand replay in the next few days. Please note that today's discussion is for informational purposes only and should not be considered legal advice. We'll be addressing these topics at a general high level, We might get into some of the weeds on some issues, but for the most part, this is not advice that you can take as legal advice. We would need to look at each case because each case does depend on a lot of specifics and facts, particularly when we're talking about documentation issues. If you're interested in a more in-depth conversation, we'll be happy to connect, and our contact information will be provided at the end as well. If you have any questions during the presentation, please use the Q&A tab. Be sure your name is visible so we can follow up if we're unable to address your questions live. If we have time at the end for Q&A, we'll be happy to engage. We'll answer as many questions as time allows at the end, and for that, if we don't get to it, we'll follow up with you directly. If questions come up afterwards, we encourage you to reach out to us at any time. And now, with that being said, all the legalese out of the way, let's talk a little bit about the State of the Union, why all of you are here. And the State of the Union is strong, but for CMS auditors, not for providers. Why do I say that? It's because audits at an all-time high. It's very rare for us to get a wound care request for documents from a UPIC auditor, that's a Uniform Program Integrity Contractor, and then be able to say, oh, this is great, we like all your records, zero overpayment. In fact, we've seen the opposite. We've seen practices that in the past received passing scores, all of a sudden get told, you don't know what you're doing. You're not doing something correctly. And when they get that, it's, you can imagine, incredibly frustrating. We had one practice who sent out records and received a 0% error rate. Just months later, they were audited. Same practice, virtually identical records, 100% error rate. That doesn't jive. There's no reason for that to happen when we know the practice, their documentation is good, the medical necessity is there, and they're doing everything correctly, documenting it properly. So why is it that they're doing this? They're doing it because, one, the CMS has realized they're paying a lot of money in wound care services, particularly skin grafts, which is what we're going to be talking about today. And they want to dissuade you from appealing, because if every time you send in an appeal, a first level appeal and second level appeal specifically, if you get denied, they love that because they're going to rubber stamp that denial and hope that you don't proceed to the third level, the ALJ, where you have the best chance of winning. So audits are across the board at an all-time high, but specifically now in the wound care space. There's wound care scrutiny on the companies and the providers. This is something that we saw play out about a decade ago with pain creams, where they first started auditing providers, and then they started auditing, the pharmacies and manufacturers. So this is something that right now we see in the realm of payer audits, but that could develop into something more nefarious, where they could go after the actual companies themselves, the marketers, the salespeople. It's a script that we've seen before. The monetary damages sought are tremendous. We're talking about routine low six figures to high seven figure amounts. We rarely get something that's less than six figures. I don't think I've seen one, and we're probably handling about 24 audits right now. The average is probably in the 2 million range. We've seen as high as 5-6 million. The lowest we may be handling is maybe $150,000, but usually those payers will get multiple audits for $150,000. So when you add up an aggregate, their total exposure, many times they're in the $500,000 to $600,000 range. Okay, so how do these overpayments start? They always start the same way, okay? No practice has ever received some multi-million-dollar demand out of the blue. They start when usually a UPIC auditor or a RAC auditor, one of the recovery auditors, you ever get a letter from somebody that identifies himself as a UPIC or RAC auditor, that's when you lawyer up right away, because they're automatically putting you in the potential category of fraud, waste, and abuse. So RAC auditors, UPIC auditors, they start by auditing records. The easiest way for you to get an overpayment in a wound care case is to send them the records they're asking for. That may sound like a total, misconception of what should be happening, but the reason it happens is because you have auditors who will ask for dates of services, but they happen to leave out, well, and send us also the conservative care you did, which if you don't have and you don't document, you're not going to get paid. So you have to be careful there. You have to be careful in just sending only what they ask for. This is why we say get a lawyer involved, get someone like Jim involved so that we can proactively go over, is there an LCD on point, a local coverage determination from the CMS? If so, what is required under the LCD for you to get paid for this code? And then we walk you through your document production to make sure you're not missing anything. If there's something that is missing, can you do an addendum at that time? Did the ship sail on that? Can you do an attestation, which is something different? You never want to change the records because that's going to be fraud and you are going to be in serious trouble. So it always starts with an audit. And you have to respond timely and you have to do a full production, because if you don't send all relevant documents, they're not going to care that you really documented well the wound measurements, or that you showed there was no wastage, or that you took great images showing that the wound was closing and you had really good progression of care. That's all going to be for naught if you didn't send, let's say, the conservative care. And that's why when we get involved, we make sure that we respond to an audit in a timely fashion. You cannot miss deadlines with the CMS. It's a full production. We're not leaving anything out. And we also make it easily digestible for the auditors, because if you're going to ask an auditor that's probably overworked and underpaid to take the time to really dig into the charts and records, to forget it. They're not going to dig. They're not going to be digging in to try to find a way to pay you. They're doing the opposite. If you don't clearly show me that you should have been paid for this, we're taking that money back. So make it easy on them. Never outsource production to someone who doesn't have any skin in the game. This is something that happens a lot. You will get a UPIC audit, you will get a RAC audit, you will get an audit from a private payer and say, I don't want to deal with this. Have someone from, the front desk or the back room or someone put together the records and send it out. I don't need to look at that. I have to spend time with patients. Yes, we want you to spend time with your patients. Answering an audit, dealing with an audit is a full-time job. That's why Phoebe and I are employed. That's why Jim is employed. These take a lot of time and effort and attention to detail. And you can't outsource it to someone who's just going to cobble it together and send it, with things backwards, upside down, send the wrong patient chart. You can't do that because they will always deny those audits, and then that will just bring more scrutiny on you. So please don't let somebody else answer for you. We've had some horror stories that led to multi-million-dollar demands because the person that was doing the production just sent the bare minimum, and you can't do that either. Don't ever send the production without reviewing it first. Again, not only is it, your credibility on the line, but it's your money on the line. They're going to come back for 100% of what they paid you. They don't care that 80% of that, skin graft went in payment to the lab or manufacturer that sent you the skin graft. 100% was paid to your practice. 100% needs to be repaid by your practice. So it's crucial that you make sure that everything that needs to meet the CPT requirements for that code is met. And again, always keep a copy of what you sent out, because if something happens in the future where they say they didn't receive something or that something is missing, your attorneys, your coders are going to have to review exactly what you sent out. So how is the CMS attacking providers, specifically in wound care? So their attacks range. Some of them are very legitimate. They scrutinize documentation requirements. And others, we believe, are transparent, totally fabricated, made up standards that they're creating just to justify an unconstitutional taking. They will attack most frequently, and these are no real particular order, but billing during the global period of a skilled nursing facility stay, calling the skin graft products used as experimental, or saying that the coding and documentation was deficient. There's a difference, and this is something that is a hard truth for a lot of our clients the first time they hear it, between clinical medical necessity and documented medical necessity. Now, Jim will be talking ad nauseum about that, the documented medical necessity part, but that's something that really you need to drive home. If you remember one thing today, remember, something can be totally clinically necessary, can be a very valid procedure. But if you don't document it, and this goes across the board for any procedure, it could be wound care, could be, anything else, injections, amnio products, whatever. If it's not clinically necessary, but not documented as documented medical necessity, meeting the elements of the code, you're going to be out of luck. And there's very little that can be done to fix that. So I will briefly touch upon this one because this area is one that we've seen an increased amount of scrutiny, and it's billing for services during a skilled nursing facility stay. And under the statutes cited here in this PowerPoint presentation, you have a copy of, a skilled nursing facility is responsible for consolidated billing. Most of you know what that means. So if it's a routine nursing or therapy, if it's ancillary services, supplies, things like that. Wound care can actually fall into that as well. And when wound care falls into the skilled nursing facility consolidated billing period, which is a mouthful to say, then you're supposed to bill through the skilled nursing facility, not through your own company or your own tax ID. Medicare pays a skilled nursing facility a bundled rate, and outside providers have to bill the skilled nursing facility, not Medicare directly. That's for services, though, delivered to Part A residents. What the CMS is misconstruing, misunderstanding, or misusing, I'm not sure which one, is the site of service exception. So there's a key exception to the skilled nursing facility consolidated billing rule that's based on site of service. So if you use a place service code on your bills for office or home, so you were at the patient's home or the patient came to your office, then that's an exception. Also, when they're no longer Part A but become Part B patients again, then you're not supposed to be billing through the skilled nursing facility because now they're no longer subject to the consolidated billing. If a patient, I don't want to say graduates out of Part A, but if they stop being Part A participants and become Part B participants again, then you should bill Medicare directly. Again, we're seeing auditors misconstrue or miss or ignore that rule altogether. As a general rule, if the patient's not physically present in the skilled nursing facility and the service is not arranged by the skilled nursing facility, then the service is not subject to skilled nursing facility consolidated billing. There are some additional caveats and additional exceptions where you could still bill Medicare directly, even if you were providing the services at the skilled nursing facility. And Jim may touch upon that during his time as well. But this is a issue that you're going to have to be wary of if a lot of your patients are at skilled nursing facilities, because it's one that we're seeing more and more often. So whereas before we would see it maybe 1 out of every 10 audits, now we're seeing it 3 times out of every 10 audits. So it's something to be wary of because the CMS is moving in that direction. So I'll turn it over to Phoebe because there's another hotly contested area that the CMS likes to use a lot when denying these services.
Thank you for that background, Guillermo, and thank you also to everyone for being here with us today to discuss these wound care issues. So I will be specifically talking about a pretty alarming trend that we're seeing more and more frequently in these CMS audit matters. And specifically, we're seeing claims being denied on the grounds that the certain types of wound care products being utilized are experimental or investigational as they deem them. The justification that CMS contractors typically give when denying in this manner, they give some combination of what you see on the slides right now, which is that the product is not supported by double-blinded, humanized, randomized clinical trials, that the products haven't been featured in peer-reviewed journals, or that they're not included in consensus guidelines from specialty societies and the like. Based on those standards that are up on the slide, really without doing any type of review of the literature that's out there or any review of databases, they state that these products are investigational. That's their conclusion. And so therefore they don't have to pay for them. Very convenient of them. But in reality, there's no statute, regulation, local coverage determination, or guideline out there that requires the specific type of evidence that they're citing here up on the slide. And really, the only legal standard that's required under Medicare is that an item be deemed medically reasonable and necessary. There's nothing in the law that demands a specific study type to meet that threshold. And so what we're really seeing, and what Guillermo kind of touched upon already, is CMS contractors really just outright creating, making up with their wonderful imaginations, or just heightening standards that simply do not exist in any policy. And then they're in turn using those standards to deny very valid and clinically medically necessary claims. And then what we're seeing now is even when providers meet those standards cited, up on the slide again, for example, by submitting studies that support in the entire product classes, the contractors then shift their argument once again. So now suddenly the claim is denied because the studies weren't product specific enough, or now the studies are denied because they weren't good enough, because they weren't the exact wound type being studied, or they weren't done on the exact patient population that's at issue. And it's very alarming to see these types of denials, especially when considering that no regulatory body, including HHS, OIG, or FDA, has ever deemed these products to be investigational. And in fact, these products fall under an FDA categorization, Section 361 of the Public Health Service Act, and that governs human cells, tissues, and cellular-based tissue-based products. Some of you also may know them as HCTPs. If you don't know, I will tell you right now that they are regulated under a rigorous framework. They're considered low risk, well characterized. They specifically undergo strict donor screening, infectious disease testing. They follow good tissue practices. They're required to register annually with the FDA. They have inspections. They're monitored for compliance, adverse events, and the list goes on. These products specifically do not require pre-market approval when they meet certain criteria and when they're used appropriately. And that pretty much brings me into my next slide, into the related denial reason of non-homologous use, which is being basically cited almost as often as the experimental investigational denials, and they kind of go hand in hand together. So in this type of denial, contractors are essentially claiming that because these products are being used for what they say wound healing, they claim that that constitutes a non-homologous use of the products. Or in other words, to explain it in a way that like I was able to wrap my head around it, they're basically, alleging that these products are being used in an off-label way when they're being used for wound healing. And then of course, they're saying that they aren't covered because of that reason. But the FDA defines homologous use, and it's also up on the slide here, as when a product performs the same basic function in the recipient as it did in the donor. In a majority of matters that we're handling, providers are utilizing these products as intended as wound coverings. And they also tend to document that as well in their notes. And when they use it as a wound covering, that does meet the definition of homologous use. And so where contractors are getting it wrong or overlooking, just ignoring, is that they're fixating on the fact that these products, in addition to acting as a wound covering, also promote and stimulate healing of the wound. But it's in reality, that's just a secondary benefit of utilizing these products, and it's not their primary function. And to make it like more easy to understand and to put it very simply, it's kind of like a bandage, a Band-Aid. A bandage's main role, if you have like a cut on your wrist and you have a bandage, is to cover and protect a cut that you may have. But it while it acts as a cover in its primary function, it may also stimulate wound healing. But just because it also stimulates your cut healing doesn't all of a sudden make it an off-label use all of a sudden. And that's what the contractors are claiming here, and that's why they're getting it wrong. So by labeling these products as non-homologous, they're just entirely missing the point. They're entirely out to lunch, and it's very, very difficult to make them understand, something that they just can't wrap their head around. And in reality, what we're seeing with these two issues that I just spoke about is really just fallback tactics that CMS contractors are utilizing more and more just to keep the claims denied. And a claim might be denied at first based on alleged documentation issues or something missing in the LCD. But then when we assist providers with rebutting those initial arguments, the alleged deficiencies in the documentation, and we do so with Jim Tudor and his assistants as well in their team, the contractor then tends to shift gears. And so all of a sudden, it's no longer the deficiencies in the allegation. And even we've seen them dropping LCDs, and then they're shifting gears into these investigational and non-homologous use throwaway issues is what we call them, to keep the claims denied. And my final point is that, these types of denials are unfortunately just trapping wound care providers in a very prolonged, expensive, and extensive appeals process. They're being subject to multi-million-dollar overpayment demands. And this is all despite the clinical results that they achieve for their patients. And in turn, that ultimately discourages them from using these products. And at the end of the day, unfortunately, negatively impacts patient care. And that's a great transition into Jim's section, because he's going to walk through some of the documentation best practices, which at the end of the day, solid detailed notes will, be the best tools to avoid these denials from happening in the first place.
All right, great. Thank you, Phoebe. So let's take a deeper dive right now into the documentation requirements. And I'd like to start by saying, and I know that you and Guillermo can both attest, there's nothing more infuriating to a provider than getting a letter in the mail from Medicare or whatever payer saying your services are not medically necessary, quote unquote. It's like confusing, confounding, infuriating. We've heard, providers being not very shy about expressing their true feelings about getting something like that. But what Medicare really means is they are missing enough pieces in your documentation, which does not allow them to make a medical necessity determination based on how they define it. For that, you have to go to the medical policy. But a lot of these things come down to often clerical errors or the inability of the provider to obtain certain pieces of information. And to that respect, a lot of the findings, and we've got some very, let's call them profound examples coming up. A lot of the findings are very surprising to providers. It's like, wow, we have, the most organized, thorough notes. How could we even be in this situation? I mean, we think we've covered everything, but they're saying that we didn't. And looks like a lot of the things that they're citing are just kind of like small, trivial, nitpicky things that, at the end of the day, really don't shouldn't give rise to a determination that my services are medically unnecessary per se. But this is just, it's, if you look at a lot of it here, it comes down to some of the things that is either somewhat out of control, entirely out of control, varying degrees of capability that the wound care provider has in meeting all the requirements to the umpteenth degree. And trust me, as I mentioned in my little preamble earlier, they give you a list of bullet points in these medical policies. And if you even miss one of them, they technically could take back not just the money for a particular treatment, but perhaps, an entire episode of care. I was just looking right beforehand at one of the review sheets that our audit team uses for skin substitute treatments. And there's actually, harvested from the Medicare LCDs, there's like over 40 different checklist items here, which is, just purely astounding. And I have been doing in recent memory a lot of education with providers who seek to, it's like, where, take a look at our charts, and where do we get the biggest bang for the buck in, in modifying our documentation to meet the requirements of the LCD. And a lot of it seems to be concentric around the initial intake, the first visit in the office. Which really is, if you could back up a slide, Phoebe or Guillermo. Yes. A lot of it is concentric to that first visit, because these are the things that are hardwired into the Medicare LCDs. And I think at the top of the list, and what seemingly is at the top of all of the overpayment explanatory demand letters, is conservative care. The records just simply don't show that, or they don't show it to the degree of detail that Medicare is looking for. Sometimes there's some nebulous areas, associated with these audits because, well, what might be sufficient detail to you, Jim Tudor, might not be to, the guy sitting across the conference table looking at the same note. And I'm sure pretty much everybody who's attending today knows that, coding and billing documentation, is rife with areas that are, kind of subject to the eye of the beholder. And if you're being audited to begin with, it means that you're probably, on the radar for some reason, which could be overutilization, too many of this code, not enough of that code, overutilization of certain modifiers. The takeaway there is too much of something usually triggers the audits. And with that mentality in mind, the auditors are not really all that generous, particularly about the gray areas, such as the conservative care, which is, they want to know exactly what was done, did the patient treat it? Did the patient see another provider to have it treated? Was there some combination of both? How long was it done? According to the LCDs, at least 4 weeks or more of conservative care is required. And oftentimes, I'll see a note is generally silent about that. And how did the patient respond? These are all, in Medicare's opinion, at least, key factors to know before you even consider initiating skin substitute treatments and grafting and so forth. How successful were any past skin substitute treatments? Because sometimes patients come back, sometimes patients are referred by another wound care provider. And when we say wound care providers, we mean, it could be anywhere from, typical, wound care specialists to podiatrists we're seeing a lot. I've even had some other, provider specialties recently, PCPs. We've gotten Medicare audits for all of them. But if they have experienced any past treatments with grafting, did they succeed? Did they fail? This is imperative to document in your chart because Medicare wants to make sure that you're not paying for something that the patient is just not responding to. Granted, there's a lot more to the clinical picture than that, but takeaway being you should really have, as strong the documentation as you possibly can with respect to past treatments. Original size of the wound. So this seems to go a little bit beyond just that, not documenting the baseline wound assessment and the dimensions there in the office on that first day. We've even seen citations from Medicare saying, well, what was the size of the wound before you guys assumed care? And you're thinking, well, wow, we might be a little bit limited in our ability to, express that to the layer of granularity being, requested by Medicare. But again, bearing in mind what I just said, they feel that they can take liberties with a provider who's an outlier, quote unquote, in some way. So some of that fuels these citations. In my opinion, there's no question about that. Status of relevant comorbidities. What was the patient's last A1C? Is their diabetes under control? Vascular disease and so forth. And oftentimes we'll hear, the provider say, I'm not the PCP or their endocrinologist, or a vascular surgeon. I don't necessarily know that I may get some information from the patient who says, oh yeah, everything is fine, but the carriers are usually looking for more specific detail than that. Nutritional status is another thing that comes up in the audits, that making sure that the patient, isn't nutritionally deprived, malnourished, has some conditions, nutritionally related comorbidities, which can lead to perhaps them not being a candidate to receive this type of service. Smoking status, do they currently smoke? Are they still smoking? Was any counseling provided to them? If they're still smoking, did you provide counseling? Things of that nature. Next slide, please. So, that giving the information right from the get-go, I think, is the most important piece of advice. I've seen beautiful EMR templates that really chronicle that entire series of treatments to the utmost degree. But if you're lacking in particular, and I mentioned there's like 40 different bullet points here, and we just went over 5 or 6, that stuff that, kind of emanates from that initial intake, or the ability that you have of getting that information right from the beginning, is absolutely key. So you might want to have a template that really has specific questions for the patient. If that patient is obviously going to be, vast majority of the time your source for a lot of that information. What did you do? How did you treat it? Did you apply, topical creams and bandages and dressings? And again, we are talking about a senior population, so their ability to recall some of that may be somewhat compromised. But in the end, you want to make it abundantly clear in your records that you exercised proper due diligence in trying to obtain all this information, to the best of your ability. They know that sometimes, it's difficult to get this, the level of granularity that they seem to be requesting. But just making sure that if the patient is a difficult historian, making sure that you mention that in the notes could have some potential value in the event of an audit. With respect to outside providers treating the wound, and I understand that sometimes these might be fairly emergent type situations where there's not a lot of time, there's not much of a gap between the time of the initial order or referral and that first visit in the office. But I would highly, highly recommend that you try to obtain the notes from that referring provider before they even get there in the office. Again, that's, that's the expectation. These are the things that Medicare expects. We even get that from, providers like DME providers. It's like, really, they want me to know whether or not the offloader knee brace was medically necessary? I'm just filling the order. So it should be, a lot of that being more incumbent upon the referring provider or ordering provider to provide. But, I'll mince no words on this. They do expect this from you, the wound care provider, to provide all the evidence up front that you're meeting their guidelines for medical necessity, no matter how nitpicky you may perceive it to be. So trying to get the notes from those referring providers, I think, is paramount importance. Other providers treating the and we're making reference here to both other providers who've treated the wound or other providers who've treated the diabetes and whatnot. Sometimes, especially in facility settings, it's advantageous to obtain the facility records. Even in a situation where like a nursing staff may have cared for the wounds, even though they're not a provider eligible to submit like a Part B bill, those are still healthcare providers. And the conservative care in particular, they may have done a pretty fair share amount of that. And you want to make sure that again, if you're called to the carpet, you need to produce all of the evidence possible that they met those guidelines for conservative care and, the comorbidities and everything that's associated with that initial visit. So this is where things get real, folks. This is these are redacted, de-identified, with names omitted to protect the innocent, overpayment demand letters for 2 wound care audits. And this is the tip of the iceberg, people. That first document, which we give you kind of I'm not sure if everyone can read the fonts, but it's really a list of so many of the things that I've already talked about with the conservative care not being documented and all of that. So it's just astonishing how even not meeting 1 or 2 of those requirements can result in just a potentially existential overpayment demand and penalties that really, at the end of the day, again, seem in the overall scheme of things relatively trivial, not medically necessary. Well, I deal with a lot of the pictures as well, because again, when we're usually asked to assist with an appeal, we get the full compendium of records that were sent to Medicare, including pictures. And, just in looking at that and in mind, you don't have to be a clinician to know that particular wound that I just saw in that image is medically necessary to treat. But this is the process that they go through. No baseline wound dimensions. How has it been treated? Status of underlying comorbidity. And then you also see other items: no referral, no physician's order, no documentation of the smoking history. Again, something that you would think that, well, is that alone going to be? Usually there isn't 1 or 2 citations anyway. They're trying to really pile on and say, you didn't just meet 1 or 2 things. You didn't meet, 15 different things. Modifier 25 at the very end of that $1.2 million overpayment demand letter, you see some reference to that. And that refers to the physician's ability to bill for an E&M office visit code on the same day as the treatments. And in recent years in particular, they've really brought the hammer down on that one in particular, because they really are of the impression that, particularly if you're going to see the patient for a treatment and it's pre-planned in advance, and you're really not doing anything else except all the work that goes with that treatment, that they really don't want you to be billing for a visit separately. They're saying that little assessment that, the E&M coding assessment is really associated with the procedures, kind of built into your reimbursement for the procedure. So by billing for the E&M with the modifier 25 separately, they regard that as being a form of unbundling per se. So this is real stuff. This is just a small, piece of what we deal with. But as you see on this slide here, it doesn't end there, certainly. Not documenting wastage. We find that in a lot of audits. And I think that oftentimes the mentality may be something along the lines of, well, if we tell you that we applied X number of centimeters of product, and the wound was Y centimeters, all it takes is a little simple math to be able to determine what the wastage is. And that's what we say when we formulate these appeals. It's like there's definitely enough evidence in the notes for any auditor to be able to figure that out. But it seems that they're wanting a specific statement. I applied, 18 centimeters of product with 6 centimeters of wastage. And then you report the wastage separately with the JW modifier. You get paid for the wastage, but they want you to document that separately and then also report in a separate line item with your Q code the number of units that align with the wastage. If you don't do that, it's just fuel for another bullet point, basically. Not documenting pre and post debridements. Oftentimes, when we see that before and after a skin substitute treatment, sometimes we hear from providers, well, the reason why I don't do that is because, the wound doesn't really change significantly in size. I've just, did, trace debridements, removal of, some granulation, but really, the pre and post is really the same number. So I don't document the same dimensions, twice in the same note. However, they don't explicitly say that the wound didn't fundamentally change in size in their progress notes. So that's very commonly cited. Not mentioning that the exam revealed no counterindications to treatment. So we've often seen something that, where, it's one part of the fuel. It's like no evidence that the patient's diabetes or vascular disease were under control. But meanwhile, there's the examination of the wound, on physical exam revealed no counterindications. It appeared the patient was getting adequate blood flow. There's no signs of infection. So clinically speaking, from the provider's perspective, there wasn't any counterindications to doing the procedure on that specific date when the patient had the procedure, which again is part of our spiel when we're appealing these, these findings and sending it back. But, just making sure that sometimes just to let, an extra statement in the notes saying that there were no counterindications to treatment on this day. No indication, at least visually, that these underlying comorbidities were out of control because the patient had the ability to receive the care. So more avoidable mistakes, failure to document serial wound measurements. I've seen lots of great templates which are really just spelled out, for each individual wound, you have this whole chronology of including the wound measurements, how they responded. And I've seen other forms of documentation, which is kind of alphabet soup, and it gets really, really confusing for the auditors. In their defense, when they're dealing with that kind of note where, it's really difficult for them to track if you're addressing multiple wounds, how each wound responded. Baked into the LCDs and the policies is the premise that the patient is receiving benefit from the treatments. And if they can't establish that because those serial measurements are not documented or not clear in the documentation, that's, fuel for them to try to take money back, and a lot of it. Unclear as to why the number of applications exceeded the norm. So a lot of that should be self-evident, but there are times where maybe if you're going beyond, I'm not sure. I know they're changing the LCD, the number of treatments, I believe, is being extended like from 4 to 8 or something like that. There's a revised version of the wound care LCD that's out there. Not in effect yet, I don't believe, but I think they're increasing the number of applications. Then beyond that is where the real questions arise. So again, things maybe should be self-evident. Not everybody responds the same way to treatments, but putting a statement in your note describing why in no uncertain terms, bearing in mind that even though Medicare says that clinical reviewers are involved in many of these audits, sometimes I'll look at the responses that we get, and it's like, well, a clinician, the information they're citing is deficient is right there. Notes, how could they have possibly missed that? So I think that it's kind of a team effort, and maybe you have, certified coders and folks who are not clinical by any stretch of the imagination looking at your notes, and they may not be able to pick out those reasons why it's self-evident the patient isn't responding. So to add something to your documentation to make it clear, especially when you're exceeding those predefined thresholds, I think could only work in your favor. I mentioned the images earlier, and I've had providers who said, we didn't take them, we didn't consistently take them, we forgot in the first pass through to send them. Are they really going to ding us on not sending the images? And the answer is absolutely. As I've mentioned, they can get any of those 40 or so bullet points. If you don't comply with it, they can definitely use that against you. So please make sure to take the images and submit them. So we've been up until this point in time, we've been talking about things that relate back to a Medicare policy, other payer policy. When we refer to LCDs, local coverage determination, and NCDs, national coverage determination, we're talking about Medicare policies, LCDs administered by your Medicare carrier, and NCDs, which is kind of like a global national level policy. If there isn't a particular policy which governs that particular type of service, i.e., let's say the type of wound that you're grafting is not a DFU/VLU, then what happens? There's no overarching authority in writing, at least for Medicare. So what happens then? And really, if you listen to what they tell you, it comes down to standard of care. Are you following, the generally accepted standard of care for the treating of that particular type of wound with that particular type of product and conservative care and everything at the time that you're addressing it? Drugs and biologicals, I'll not go into details here because I think Phoebe did go into that, defer to the previous FDA discussion where something is called into question as being non-homologous. I mean, that can definitely lead to some of those issues that we've been seeing. Following the basic CPT and ICD-10 coding conventions, which most providers do, but really in the absence of the overarching policy information, there's even more importance placed on that. And then out of jurisdiction LCDs, which is kind of a controversial topic. We've even had this emerge in administrative law judge hearings where some of them will actually say, okay, I can accept this, your points based on an out of jurisdiction LCD. Because if you look at all the LCDs around the country, they're basically similar or, the same in many, many respects. And sometimes we even see some flavor of that in audits. But my recommendation would be, if you're interested, if you happen to be in an area outside of governing LCD, which would be to try to formulate a policy that's harvested at least to some extent based on the Medicare policies, checklist of, documentation item, all the things that we've been really talking about here today, and some of the other bullet points too as well. Just making sure that you cover all of the bases, because sometimes we know that the auditors kind of defer. They look at those out of jurisdiction LCDs, and it influences their decisions.
Thanks, Jim. And thanks, Phoebe, also. And thanks, everybody, for joining us today. Our direct contacts for myself, Phoebe, and Jim are up on the screen right now. Just as a reminder, as we mentioned earlier, a link to today's recording is going to be included in the follow-up email for you to review at your convenience. We really hope that you found the discussion insightful and informative. If you have any questions or need any further assistance, please don't hesitate to reach out to us. We're each here to support you as you navigate these complex issues. I'm going to thank everyone for your participation today. I want to thank Phoebe and Jim for their knowledge and sharing everything with us. And I hope everyone has a great rest of the day and wish you best of luck if you're in the wound care space. Thank you.